no. Recording in progress. Great.
And I think we can go ahead and let folks in.
Send in the clowns. Welcome, welcome, welcome.
Welcome, everyone. Lots of friendly faces I see popping in. Laura Thomas, Tracy, Zoe, hello, hello. All right. Well, I'm just gonna get started then. We are so excited to start our event right now. My name is Rajani Gudlavalleti. I use she, her pronouns, and I am the director of mobilization with Baltimore Harm Reduction Coalition. And we are here for part 3 of this event series we've been doing, which is called More Than a Needle, More Than a Crackpipe, Racism and Safer Drug Use Supplies. And tonight we're going to focus on essential history to know. And we are very excited. We are a lot of history nerds here at BHRC because it's so important. And we're very excited to be joined by Dr. Hansen, who I'll introduce in a second. I'll just say this is an hour event. We are, I'm going to get into setting the stage a little bit. Dr. Hansen and I are going to get into some conversation, there'll be some slides, there'll be some really interesting info. And then we're going to close out with some next steps, really action items. And I'm actually going to also start doing a recording just for backup recording. I forgot to do that. Okay. So, yeah. And so we're going to continue. And we're going to end the conversation tonight with what can I do with this information? What are some action steps? What are some existing organizing spaces to join with BHRC? What can I do tomorrow? And we will also share out next week the YouTube, we're going to share the recording of this on YouTube. But for folks who have registered for the event tonight, you'll get a kind of early peek to the video, and then we'll have it public starting next week. But what I will say is, because it's an hour, we're just going to get into conversation. There won't be any Q&A. You are welcome to come tomorrow to our Instagram live at around 10:30 a.m. with Cam and Harriet from BHRC, where they're going to digest some of the lessons learned, get into conversation, talk about next steps, and so all that kind of stuff. So if you do have questions that you really want to get out there and have conversation, that is what the chat feature is for. So please use the chat. BHRC staff are in there. Very excited to talk with you via typing. So put any messages, thoughts, questions in the chat. Won't be able to ask questions out loud today, but that's okay. Don't worry about it. BHRC is always around for that. And you can join Harriet and Cam tomorrow. So today we are going to, and of course this event is being recorded, just so you all know. So we're asking you to please keep your cameras off and stay muted for the duration of the event. Okay, so setting the stage. Dr. Helena Hansen is an MD, PhD, psychiatrist-anthropologist, professor and chair of research theme in translational social science and health equity, as well as associate director of the Center for Social Medicine at UCLA's David Geffen School of Medicine. She has published widely in clinical and social science journals on faith healing of addiction in Puerto Rico, psychiatric disability under welfare reform, opioids and race, ethnic marketing of pharmaceuticals, and structural competency. She was connected to BHRC via common friends at the Legal Action Center's No Health, No Justice program. I just wanted to add that bit in. Shout out to Tracy and folks at Legal Action Center for making this connection. And I want to just do some continued stage setting before really giving the floor over to Dr. Hansen for some conversation. So as many of us probably know, BHRC in our mission, we really want to emphasize that harm reduction is part of a broader movement for social justice. And so as harm reductionists, we must support an end to the drug war, which does require us to interrogate any dedication to medical institutions and medicalized policies. And so if that is something like, what does that actually mean? That's what we're talking about today, right? We talk a lot about the often last, if you joined us for part 2, we talked about a dedication and reliance on incarceration and the criminal justice system and policing structures. Well, there's also this hyper medicalized approach that has been developed towards addiction, towards really just how we exist in our bodies, that is also extremely harmful, which we're going to get into that history as well. And so we have to interrogate that and think through, what does that mean? And our culture and institutions are designed to police and uphold racism and classism. So when we say institutionalized, and this is something I know I myself and my Harriet Smith, our director of education, we've really learned this through our partners at Baltimore Racial Justice Action, that this institutionalization is through medical institutions, police institutions, child welfare, housing, banks, all sorts of institutions we have to interact with all day, every day. It really perpetuates this culture around policing and the insidiousness of racism and classism within it. So we have to remember that. So knowing that, that's the groundwork for tonight. We want to name, of course, we've been out here. I'm sure it is not new to you all that BHRC is all day, every day yelling about how we need to decriminalize paraphernalia in Maryland. On December 6th, in just 2 weeks, which is wild to me, Maryland legislators can decriminalize paraphernalia. They already did it. They passed Senate Bill 420 in April. But then, of course, a month later, Governor Hogan vetoed that bill. And so on December 6th, our legislators have the opportunity, under the leadership of Senate President Ferguson, who did vote yes in favor of the bill back in April. Under his leadership, our Maryland legislators have the opportunity to override Governor Hogan's veto. And if they do so, when they do so, then paraphernalia will be decriminalized immediately. Actually, it will be effective in December. And so it's such a beautiful, amazing thing. And so this picture is with Delegate David Moon, I believe a 2019 bill hearing for our bill to decriminalize paraphernalia. So you'll see some familiar faces in that picture. And so that is an issue that we're really, really focused on right now. It's our big policy political effort. And so how do all these conversations connect, right? So decriminalization of paraphernalia is about institutionalizing a culture of safety and dignity, right? When we talk about abolishing the police or abolishing systems that are harmful, it's not just, okay, let's end it, that goes away now. It's talking about, what are we creating? And so decriminalizing paraphernalia to us, we know, is a step towards creating so much more, right? Bigger, bolder policies that we need. And so that's what we're talking about. And so policymakers, although they did vote in favor of SB 420 and pass it, of course, it was a very controversial bill. It's been controversial since jump, continues to be. Their hesitations about SB 420, and really their hesitations about all harm reduction policies, our overdose prevention site bills, Good Samaritan, you name it. These hesitations come from deep roots of oppression and ignorance of history. Point blank, because we all know we've been throwing evidence for decades and decades. Dr. Hansen has been in it, right, bringing evidence to the table. Our partners and friends at Hopkins, Dr. Susan Sherman, all sorts of researchers have been doing this. We have been presenting the data, and they still persistently do not pass so much legislation. And so at a certain point, we do have to stop and think, what is this about? This isn't about you needing evidence-based approaches. This is about some icky, insidious stuff going on. So we have to acknowledge that, especially when we implement these laws of decriminalized paraphernalia. Then what, right? Then we have that out in practice. How are we going to ensure police are actually upholding this new law? Because they are definitely upholding those old systems. So those are things that are on our minds and why we wanted to have this conversation about history. And we need to understand a broader picture beyond the needles and the pipes. That's why we're saying more than a needle, more than a crack pipe, right? Our syringe service programs absolutely are about giving these life-saving supplies to folks from my hand to your hand. Here you go. It's also more than that. It's about that warm welcome. It's about people knowing Dave's name and going, hey, Dave, what's up? Yes, I'd love to see you again. Good to see you. How's the people? Let me get this supply. Let's talk about the thing we talked about last time, whatever, right? It's about that relationship. It's about feeling safe. And so those are some of the things that this is about. So it's not about the needles and the pipes. It's about this insidious history stuff. So that's sort of the stage we wanted to set. And I think it's about time to now finally let Dr. Hansen speak. And so I will turn it over. Wait, before we do that,
You said it all.
I know, right? We're done. No, we're not. Oh, I'm so excited to hear you though. Let's take a big, deep breath, actually. And if you don't mind, Dr. Hansen, doing this with me, I'll just, because this is a lot and we get really caught up in the data and the history, but let's breathe. So we're going to just relax our shoulders. Whew. And we're going to inhale for 4, hold for 3, exhale for 4. Okay, so inhale, 1, 2, 3, 4, hold, 2, 3, exhale, 1, 2, 3, 4. We're going to do it one more time. 4, hold, 2, 3, exhale, 2, 3, 4. Okay, thank you for taking that breath moment with me. How did you get into this harm reduction work? Please share with us, Dr. Hansen. Would love to hear.
Oh, well, wow. So I think that asking me how I get into harm reduction work calls into question, what is harm reduction? And one of the things that we can discuss is, what counts as harm reduction here as
Right.
opposed to other places. We'll get to
Okay.
that as we go, because there are places in the world where things like methadone and buprenorphine are seen as harm reduction, and they're combined with supervised injection as a whole host of other things in ways that we don't do here. I want to date my work in harm reduction back to the early 90s. I just graduated from college and I started working for the National AIDS Fund at a very particular moment in time. And it was quite inspiring, and I know that harm reduction has deep roots in AIDS activism. And in particular, when it comes to racial justice, at the time, there was a tenuous alliance between largely Black and brown heroin injectors who were, getting HIV at really high rates, and men who have sex with men. Many of the outspoken activists were actually affluent, largely white. So it was interesting to see all of the activism around syringe exchange, mutual aid when it came to educating each other about safer injection practices, a lot of those things coming up as a part of this tenuous alliance. But it was very clear that this was a racial justice issue from the beginning, and that harm reduction was about way more than a technocratic public health intervention. It was very much a political movement and a community. So this is what inspired me from the get-go. And from that inspiring moment in my 20s, my early 20s, I decided to take a research route, which fortunately I've been able to combine with work on the ground. So I'm a methadone prescriber, buprenorphine prescriber. I've worked on harm reduction bans and things like that. And that's been vitally important for the research and writing that I do, right, that I hope, is policy engaged. It's always a tricky thing. As you're pointing out, research evidence doesn't translate neatly into policy change. There's a huge gap there. And so that's the gap that I live in a lot of the time. But through alliances with people like Tracy Gardner and with my dear friends and co-authors at Drug Policy Alliance, I try to work with people who know a lot more about policy and policy change than I do, to bring the evidence, so to speak, where it needs to be.
I love that. I love so many things that you brought up. I mean, for one, as someone who is a community organizer and just really, I take that as such a part of my identity. I think it's so important to know that we cannot all be experts in all things, right? And I constantly am stressed about needing to be able to deliver this message to so many different audiences. How do I translate this to policymakers, providers, to my peers, to people who are actively out in the community facing issues every day? And so I really appreciate you mentioning, like, this is where I fit, right? This piece here, which is a very tricky place to be, is that translation. So I really appreciate all that you've done to add to the breadth of research, and it's really exciting. And also shout out to mutual aid.
Likewise.
Yeah, thank you. And such a shout out to mutual aid. I love, because that's become such a it's a fashionable term since the beginning of COVID-19 in the United States last year, and mutual aid efforts keep coming up, which is fantastic and beautiful. But I just, I can't help but see, like, we've been doing this for a long time. Our work is so rooted in mutual aid. So I love that it's, really becoming a term people know. So thank you for mentioning that. So let's get into the content stuff. I wanted to make sure to, we did read a lot of your research and watch the videos that you have. And for everybody out there, please, you can just really Google Helena Hansen and you'll find videos and podcasts and stuff to learn, to continue to learn. So, let's start here with, we at BHRC really appreciate your research and work for so many reasons. One being that you center the role of whiteness in opioid treatment and overdose response in policy. So as you have stated in research and in different presentations, we have a separate system for categorizing and disciplining drug use among whites. So my question to you is, for us working to end overdose, how can we identify this separate system, how it operates maybe in our day-to-day life?
Okay, so I'm going to try to respond in a concise way. The big picture is that this book that I'm about to publish with Jules Netherland at Drug Policy Alliance and historian of race and drugs, David Hirschberg, really, it has deep roots in my observations starting in the 90s around the introduction of buprenorphine and a whole discourse around the white opioid crisis that was changing drug policy across the country. And as I started to dig a little bit deeper, I feel that I uncovered a story about how racism, structural racism in drug policy was harming white people as well as Black and Brown. And so it might be useful for me to use some slides just to illustrate some of the findings that I and my colleagues have come up with. So let's see, do you see my screen here? All right, this first slide, you see a set of graphs here. Okay, yes. This grad student at UCLA, Joe Friedman, did this analysis with CDC data. And this is just to kind of put things into perspective. This is hot off the press. Literally, this is coming out in LA Times op-ed citation for this in the next couple of days. But in 2020, for the first time since, let me show you, since the late 90s, overdose rates among Black Americans were higher than white Americans. And the story is a little bit more complicated, but the same is true also for Native Americans. So that although what you'll see from these graphs that are by race, with the top graph actually being Native Americans, the purple being Native Americans, the blue being Black Americans, red being white Americans, and down in green is Latinx. You'll see that overdose rates are rising among everyone. So pretty sharply, and so there's a whole story to be told here, but what has been so, newsworthy over the past 20 years is white overdose deaths, kind of the American surprise that white people use drugs, particularly white people in suburbs and in affluent areas, and that they're dying as a result. It's not really a surprise that Black and Brown people die from drug use. Let me just show a few other images. So this is an image from marketing of prescription opioids, which is clearly racialized. So, our book a lot of it is about the white ethnic marketing of newly patented prescription opioids starting in the late 90s and how that created a whole other set of drug policies. But here these are some images from Prohibition era US. So this is turn of the 19th century or 20th century Chinese opium dens. So, you know, recent Chinese immigrants who were luring unsuspecting white women into sex slavery using opium. That was a recurrent theme in the news. And then here's 1914 New York Times, Negro cocaine fiends in the South who in a cocaine induced crazed state were attacking their employers, their white employers. And then Mexican marijuana madness. So these were images that were deliberately used by prohibitionist policy advocates to get prohibitionist policies passed. And they created this whole illegal world of illegal drugs and all of the oppressive drug policies that went along with that. But, you know, this was a racial project from the very beginning, no? But all the while, there was this separate track of drug use, a protected medical space for middle class to affluent white Americans. So these are images from advertising of barbiturates and later benzodiazepines like Xanax, Valium for a very actually female white middle class market, people with access to private doctors. And some of you might recall that benzodiazepines like Xanax and Valium were sold as or marketed as mother's little helper, suburban mother's little helper. So there's been this whole other space of legally prescribed drug use all along. And so actually prescription opioids fit into that, you know, so we'll go back to this ad. Okay, so this one had a lot to do with that protected medicalized space. And so the marketers for OxyContin and sister products in the late 90s, when they got approval to market these drugs very aggressively, I might add, got approval based on the assumed market for these drugs. So basically people with private insurance and people or public insurance that was going to reach into predominantly white areas that were not thought to be at risk for addiction. And doctors across the country, when they're surveyed, say that they actually believe that not only white patients are at lower risk of addiction problems, but also that Black and brown patients don't experience pain the same way. So there's a whole, you know, infrastructure around this. So from the very beginning, we've had these two tracks, right? And so that's kind of the foundation for the story of the opioid crisis. And then we come to this graph about how, you know, opioid overdose became white and then how it became Black again. And this is a very complicated story. And you and Maryland are all at the forefront of reporting on this story, but fentanyl has a lot to do with it. And so across the country, the aggressive marketing of legal, newly patented opioids opened up markets once prescription drug monitoring programs came in and tamper-resistant formulations of those opioids came in. They opened up new markets for opioids of all kinds as people, you know, were stuck, you know, in withdrawal without access to the pharmaceutical grade stuff. And then fentanyl, it's so easy to smuggle, so compact and convenient, and the cartels switching over to that. And so you have a recipe for lots of markets across the country, not only your classical heroin markets, which were large port cities and which were by design kind of allowed to crop up in Black and brown neighborhoods, but also in small town America, rural America. So we're now seeing fentanyl enter into those, you know, really widely dispersed markets. And we're also seeing the impact of this. Let me see if I can get this right here, mass incarceration. So we know that recent incarceration is a huge risk factor for overdose. People have low tolerance. They're, you know, at really high risk of relapse. If they've been off for a while, they don't have social services. They don't have treatment. They may not be familiar with the local markets. All kinds of things add up to really high risk post-incarceration. So if in the US you have Black Americans incarcerated at 6 times the rate of white Americans, and Latinx 3 times the rate of white Americans, and that in itself is a risk factor for overdose, then you're going to see back to this, you know, what we see at the far right end. But the bottom line is everybody is dying. I mean, it's really, really toxic market out there.
Yeah.
And now I'm losing the thread of what your original question was.
That's okay. No, this is, I mean, right. This is really powerful information. And I definitely I did come across this, the preprint copy of this article. And so I'm really glad that you're able to show these data from there. Wow. And something that we've talked about, and I know that you explore a lot in your research, is around how bup is prescribed, or buprenorphine is prescribed and offered versus methadone. And so I'm wondering if you can help us just kind of basically understand, what does that mean as far as how they've been prescribed.
So I'll try to give the really short version of the buprenorphine versus methadone story. They're pretty distinct. The curious thing is that both methadone and buprenorphine are opioids. And the principle behind their therapeutic effect is the same. If you give someone a legal opioid and it's sitting on the opioid receptor in their brains, then illegal, possibly more dangerous opioids can't sit on that opioid receptor. It's protective in that way, right? And it keeps them out of withdrawal. So that, pharmacologically in the same drug class, but totally different social identities. And so this is the first nationally representative sample to compare buprenorphine with methadone patients by race and class. And it's pretty clear who's taking what. That was back in 2005. And this is 2019, essentially the same pattern. This was a study in JAMA Psychiatry that reported that white Americans with opioid use disorder in clinical treatment were 3 to 4 times as likely as Black Americans to get buprenorphine, and that the most common payment method was out of pocket. And anyone who's who's used buprenorphine knows it's very, very expensive. It's actually, it's upwards of $300 a month to take it. So we're talking about a very wealthy group of people. And the second most common payment method, private insurance, and then way down the list, Medicaid. So as of 2019, buprenorphine still like a wealthy white person's drug, essentially. And there's a whole story behind that. So these are my slides having to do with the history of methadone, right? So we have to go back to 1965 and the stage that by the late 60s, there were race riots cropping up in major cities across the country. And the unemployment rate for Black people was twice that of white people. That had a lot to do with these race riots. But heroin was identified in the popular media as somehow, linked to this. And so there's a discourse around crime, the outbreak of not only race riots, but heroin related crime in Black and brown inner cities that was really pervasive, and a lot of panic and public fear, which politicians tapped into. 1965, Vincent Dole and co-authors published the first article on methadone maintenance as a treatment for heroin dependence. And the participants in the study were Black men from Harlem who were injecting heroin. And the outcomes that they reported were increased employment and decreased arrest by 3 and 6 months. So the outcomes were more, social outcomes, arrest and employment, rather than clinical outcomes. This got President Nixon's attention, right? Oops, I don't think I have photos of Nixon here, but basically Nixon made methadone the major weapon in his war on drugs. There was a real association with Black and brown inner city crime, that methadone was going to be one way to control inner city crime. And so there was a racialized discourse that was centered on crime and that was centered on control, social control, from the very beginning. And those were the associations that methadone was born with. And then if you fast forward to buprenorphine, it's on a very different historical context. We're talking the late 90s, we're talking OxyContin and sister products causing record overdose rates among predominantly white people, to whom, by the way, the drug had been marketed. So OxyContin was very deliberately marketed to white markets from the very beginning. So the drug reps that were sent out, 100,000, there were 700 drug reps, visited over 100,000 doctors' offices, mostly primary care doctors who were taking private insurance in white areas in the first couple of years after OxyContin was released. And this was highly effective. It led to a 4-fold increase in opioid prescribing within a couple of years. And we know the public health impact. And so the reaction to that was very different. Okay, so there are publicly available congressional records that document the debates around Data 2000. Data 2000 is the act of Congress that legalized private office prescription of buprenorphine for opioid use disorder. And this was a legal breakthrough, because since the 1914 Harrison Act, doctors in the United States had been legally prohibited from using opioids to treat opioid addiction. That, you know, for 80 years, that had been prohibited. So Data 2000 reversed that, enabled buprenorphine to be prescribed in private doctors' offices. And if you look at the congressional records around this, there's continuous reference to a new kind of addict, quote unquote, suburban youth that are not appropriate for methadone. And those are the exact words. So this is coded language for white middle-class people who are being affected by the OxyContin phenomenon, that methadone is not appropriate for them. We have to create a different private track of treatment. And that's really how buprenorphine was born. That's how it's been marketed from the very beginning. That's how it continues to be marketed for the most part. And I could go into a lot of detail about how all of the regulatory structures, things are, they're structured in the private market, except actually in Baltimore. And I'll say that Baltimore is a very interesting exception because the early clinical trials of buprenorphine before it was approved happened in Baltimore. A lot of the study participants were Black and brown, and a lot of the clinicians who were involved in those early clinical trials were serving Black and brown patients. And so in Baltimore, you have a slightly different history simply because that's a place where buprenorphine was tested out. But that's not what you see in Baltimore is not exactly what's been happening in the rest of the country.
Right. Well, and woo. All right, everybody, it's going to be 6 hours now. Forget it. I can't do this. Okay. Thank you so much. I mean, I know I asked this heavy question, I asked you to break down this history so well. Thank you for being so concise with that. I think a couple of things I'd like to uplift in this, if I'm able, so many things. With the testing in Baltimore, it's always fascinating because there's a lot of testing that occurs in Baltimore, right? Testing on Black folks, on Black bodies. And I thank Dr. Dorothy Roberts for always doing this research around Black bodies and research and sort of how the manipulation around science and public health when it comes to Black and brown people. And it does, even though the testing and research has been conducted in Baltimore and in Maryland, doesn't necessarily mean access exists, right? It's there's so much, and that's where I think there's in Baltimore particularly, we have such a antagonism, really, a really understandable deep mistrust of the public health and medical systems because of this. Oh, you can test on us, but you can't give us access to that. Right. And that's consistently, unless we're incarcerated, unless this, unless that. And so it's just this consistent pattern. And so I find that really interesting that there is even that history there. And then the other piece is this idea of what is used as social control, right? Even, I mean, it's marketing, but it's also, I feel, how people have marketing is also how people convince themselves, right? Like the happy white woman in the meadow is how, right? Or the mom who can't wash the dishes and take care of her little kid at the same time. Good thing I have this pill. And I'm like, good thing you do. I'm happy for you. And also like, wow, there's just no framing around social control there. It's like, this is going to help you. This is going to support you. And I mean, that's not even getting into the actual science, right? The actual scientific fact that buprenorphine is fantastic and we do need access to it. And methadone can also be really helpful for folks, right? There are so many places and clinics we work with that offer methadone that are just like beautiful spaces. They can be, right? They can be. So it's not necessarily to say that all methadone clinics are awful by any means, but there is this very deep particular stereotype. And also that's around the for-profit stuff. And of course we can get into that forever, but I think those are some things that are resonating with me right now. And another piece, of course, last thing I'll say as we continue is bringing it to this, the fact that we're talking about decriminalization, and criminalization is social control. How do you control social groups? Criminalization, right? And so that is where they seem so tied to me. And even though we are talking about methadone, right, as a tool used to control, it's just not a far cry from criminalizing paraphernalia as a way to control, right? Criminalizing holding on to even take-home methadone has been thankfully during COVID-19, we have policies that have opened up space for folks to do take-home medication, but why did it take a global pandemic for that, of course? So those are some things that are coming to my mind that I'm sure we can talk about forever. And I'd like to kind of move us forward a bit. And I'll go back to sharing my screen just so that we can be able to read the question as well. As my next question is actually in reference to our friends in Maryland, Allegheny County. So there's an article that we can definitely send out to folks later. But if you, so I apologize, I don't have the link right now, but basically, much of our work at BHRC is to educate policymakers and the public with this racial justice lens on the current overdose epidemic, right? And so your data, the data that you've shown definitely validates what we experience here in a Black city being Baltimore. And this is a steep mountain to climb because the insidiousness of racism shows up in a number of ways. So for example, 2 weeks ago, the Board of Commissioners of Allegheny County in Maryland sent a letter to Governor Hogan requesting he stand up for rural Maryland. That's a quote, stand up for rural Maryland, and support increased relief from the opioid settlement funds. We are receiving opioid or settlement funds. Increased relief from the opioid settlement funds to Allegheny County, calling themselves Maryland's poster county for the opioid epidemic. The rationale is based on the prescription opioid rates in the county, nearly doubling that of Baltimore City. So Allegheny County has about double the prescription rates as Baltimore City. Also of note is that that Allegheny County is 88% white, claims a rural identity, while Baltimore City is about 62% Black and has been hit the hardest by overdose during the current overdose crisis. And of course, as we know, long before this current overdose crisis. So our question is, how can we connect this example, your research, and the reality of the role of whiteness in the overdose epidemic to move forward? I think we are struggling with, I feel for our friends and partners in rural Maryland, in rural areas, in white areas, and it's hard, right? This just touches on so much emotion and so much frustration. So what are your thoughts on how we can connect these pieces together and kind of your reaction to this example?
So it is a dangerous framing, isn't it? The dangerous framing is one that's torn our country apart and greatly accelerated overdose and all forms of death, including COVID, from all kinds of causes. This idea that somehow the plight of largely poor rural white people is separate from the plight of largely urban Black and brown people. And one of the reasons there are so many Black and brown people in the cities, particularly in the North, the Great Migration, Black and brown people fleeing racial terror in the rural South. So these are people who have rural roots, and they're fleeing a reality of racial violence that pit poor white people against poor Black and brown people from the beginning. That's the way our system has been created and upheld, and so it's a dangerous framing that way. So one thing that I keep coming back to is reframing. What's the bigger picture here? Number one, and here's where I'm going to use an international comparison, just because we in the US, everyone on this line probably knows that we spend the most on healthcare of any country in the world per capita, right? We have the most expensive healthcare of anybody in the entire world by far. And when you compare us with 17 peer countries, other industrialized nations, we have the worst health outcomes, the very worst. So on all kinds of fronts, mental health, addiction related, physical health. So our system is anti-health, and it doesn't serve anybody, including the richest Americans. So there's a study called The Spirit Level that I highly recommend by some social epidemiologists who did these comparisons between the US and 17 peer countries, industrialized nations, found this very linear relationship between life expectancy, health outcomes, both mental health and physical health outcomes, and distribution of wealth. So those industrialized nations with the more even distribution of wealth had the better health outcomes. And those that had the worst distribution of wealth, the US being top on the pile, had the worst health outcomes. But the soundbite from the study was that when you took the wealthiest quartile from all of these 17 countries and you compared their life expectancies, the richest people in the countries with the worst distribution of income had the lowest life expectancy. So the soundbite, the US being on the top of the pile. So the soundbite is that social inequality is bad even for the health of the rich. And I'll let you ponder that for a moment, but the opioid crisis actually demonstrates how that works. We're a healthcare system that is based on profit, not public health. So that's why we have so many uninsured people. It also is why even rich people tend to get healthcare that's much more geared towards selling them really expensive products. And that could include OxyContin, right? Rather than things that are good for their health, because our whole system is geared towards enabling pharmaceutical companies and biotech companies and health insurance companies to make the biggest profit in the shortest amount of time. They have huge, huge political lobby and pull when it comes to regulatory requirements, taxation, all these, they get lots of subsidies from the NIH. So our taxpayer dollars go directly to pharmaceutical and biotech companies to subsidize their development of new products. And often these products have very marginal health benefit. So that's the system that we're in, and it hurts everyone. And so here I'm just gonna quickly, and I see Tracy's on the line. She's heard me give this example before, but it's a really convenient one. So let me see if I can pull up this slide really quickly that illustrates what happens in a system that is more founded on public health principles, because that's really what we're missing. No, we're missing, and I've come more and more to use the term racial capitalism to describe what I'm finding with the opioid crisis, because what we have is a set of companies that are dedicated to delivering profit to shareholders. That's their goal, right? So our healthcare system is based on the principle that shareholders need the biggest return. It's not based on public health maximization. Okay, our system is profit-based. And what you get in a system like that, in a country that has such a deep history of racialization, race being such a convenient way to divide people politically and line them up around things like subsidizing healthcare industries. So when you get it, what you get in a system like that is the companies will exploit racial stereotypes and racial tensions. And that's precisely what happened with opioid marketing. Bar none, they got approval to aggressively market OxyContin and sister products because of the race of the intended market. And then when the overdose crisis erupted out of that, the whole buprenorphine, the racialized buprenorphine second tier of treatment, that was legally enabled because of the race of the intended market. So we're talking about racial capitalism. What happens in a system that isn't necessarily based on racial capitalism? Let me try to pull up a slide from that. So this is France. And this is a very well-known graph among my colleagues in the US who are promoting buprenorphine dissemination. So there is a very strong group of addiction doctors in the US that are very focused on getting buprenorphine into the drinking water. They feel that this is the big solution to our overdose problem. Okay, and I prescribe buprenorphine. I've seen that it has its uses. One of my big beefs, though, is there's no such thing as a magic bullet. You have to address the social inequalities. You can't just come up with a molecule that will magically solve the inequalities upon which our overdose crisis is based. So this is a graph that shows, France very early on adopted buprenorphine, and they promoted it among primary care practices with an eye to those in low-income immigrant communities that were reporting very high rates of HIV infection and overdose. So from the very beginning, it was not a affluent white market that buprenorphine was being pitched to, because France is a country where new medications are reviewed and approved by a national body. The National Health Service purchases the medications. It's a very different system. It's not as profit oriented, right?
Right.
They have universal healthcare. they have a nationally run universal healthcare system, which means that anybody can see a primary care doctor, right? And it also it takes out the motivation to market to private enclaves like in this country. You know, if you're a pharma company trying to sell a product in the US, you must generally, unless you're selling an HIV medication or something like that, you must go for a privately insured, well-off white market, because those are the people who have the money to pay for newly patented expensive medications. Whereas in France, it was the government doing bulk purchasing and distributing through a universal healthcare system. Very different system. But what you see in the graph is that starting in 95, when they introduced buprenorphine, the blue graph is overdose deaths, all right? See 95, 565, and then by 1999, 143. The red graph is buprenorphine prescriptions. So you see this inverse relationship that overdose deaths dropped 80% in the first 5 years after buprenorphine was introduced. There's a lot missing from that story if you just leave it there, because in the US, my colleagues that are, you know, really diehard buprenorphine promoters, they'll say, look how beautiful, you know, this molecule, it solves our problems. No, if you look more closely, France is just a completely different healthcare system. Buprenorphine was introduced for a completely different clientele. And buprenorphine is not just prescribed in private offices. It's actually largely now prescribed and dispensed in community-based addiction centers that offer buprenorphine, they offer methadone, they offer social services, they offer housing, they offer education, they offer supervised injection, they offer syringe exchange. They are co-managed by people with lived experience. Activists who have lived experience are involved in reviewing, you know, the performance of these. It's a totally different system. And so that's what I use this graph to kind of get the conversation going with my colleagues here in the US. But then I point out to them, you have to understand the context in which this happened. It's so different, and it points us in the direction of where we need to go. We need to acknowledge that overdose deaths are rooted in social conditions, whether you are a poor Black and brown person, a poor white person. Affluent people are not as affected as they used to be because they have a lot of resources to shield themselves, right? But there are affluent people dying too. The point is, we have to address social inequalities. We have to do that, or we're not going to get these kinds of results. You can prescribe as much buprenorphine as you want, and you're going to get exactly what we have in this country. So here is a graph. It ends at 2017. So these graphs keep going up, right? Yeah. So look at 2002 when buprenorphine was approved. You'll see how exponentially overdoses have increased since buprenorphine was approved in this country. Lots of factors involved, but certainly one molecule is not doing it. So I hope that begins to answer what you raised.
I think you've blown everyone's minds. I'm going to set everything on fire as usual. And I think with that graph of France, I'm just thinking about what's in all that white space, right? Behind the cross of the graph, just all that white space is the context, is the history, is the systems. Oh my God. Okay. Whoo! I need to calm down for a second.
The good news is that these centers take a wide range of harm reduction interventions seriously. And in this country, actually harm reduction centers are where the action is. You know, during my colleagues who have been researching the impact of COVID, they're finding it's the harm reduction organizations that are stepping out to develop mobile delivery, to, you know, provide devices and access for people who don't have access to telehealth, to solve all these problems. That's where the living energy and creativity is. So I think that's where we should be putting our resources.
Oh, thank you. Oh my God. I love this. I love all of it. And I love Baltimore Harm Reduction Coalition. Okay. I am like really
you're working in the right area.
I know, right? Oh my goodness. Okay. So we are closing up somehow, some way this is happening. Everybody, we're going to get through this. I love the way, first of all, as a super anti-capitalist, I'm just living for the way that you talk about capitalism, racial capitalism, the sharing of capital. So something that you and I discussed, and I definitely want to make sure that we hit on this for a few minutes, is the symbolic capital of medical practitioners. So we have, you know, really calls to action, of course, right? There's so much here. One of the calls to action I'm going to ask everybody to do is let this digest, sit with this information, breathe, and take action. You know, you have to take care of yourself because this is a lot and I'm feeling it in my body. But I want to name, you've talked about the importance of combining medical training with community-based research and the power of understanding how social forces influence health, right? This is really what we're talking a lot about. So I'm wondering, we have so many amazing medical practitioners, students, clinicians who are part of BHRC's community and are attending now, I know. Can you please share some advice for our friends in the medical field and clinicians who often join our events? How do they move forward with this information?
So I don't think that what I have to say is going to be any surprise to the people on this call, actually, because already by definition, you're taking action at systemic and structural levels. I'm used to speaking to clinical practitioners who, for the most part, because medicine in the United States is very, very individualized. It's all about what happens when you're consulting with an individual patient and what you prescribe them. You know, we've molecularized healthcare to a large extent, and there's a lot of, you know, industrial pressure to do that. You know, again, pharma companies and biotech companies, insurance companies, they drive a lot of what we do under the heading of healthcare. They are definitely setting the agenda. So when I talk to, you know, my average colleague in clinical medicine, I have a different starting point with them. This group, since they're interested in harm reduction and they're here, you know, thinking about how to lobby for decriminalization of paraphernalia, you know, how to get resources for harm reduction being still illegal in half of the United States, you know, despite all the evidence that it's effective. So this is a group that's very enlightened. That said, I humbly offer up some of the language that I give when I talk to clinical practitioners who maybe aren't as far along. And that is language of structural competency. It's just a language to name something that has a really deep history that goes extends way back in history before I was doing any of this work. But I just offer up this language because this is where I've been spending a lot of energy talking to my clinical colleagues. And the idea is, so social determinants of health is beginning to catch on in clinical circles these days. It's a term that comes from public health. It does not come from clinical medicine. Clinical medicine in the United States has long been very individually based. But social determinants is beginning to creep into medical schools, you know, might get an introductory course or some introduction somewhere. What most clinical practitioners don't think a lot about is social structures. So neighborhood conditions, institutions, policies that explain the social determinants or social needs that we see in the clinic. So I use these examples with them. Let's take housing. We all know housing, if somebody has unstable housing, it's a really bad predictor, you know, it's a predictor for bad health outcomes. You want to try to do something about that, or the person coming to see you is not going to do well. And so we've begun to screen in the clinic for unstable housing. And maybe we've begun to refer to a housing agency or to a social worker who can help. But what we don't do in clinical medicine is back up and say, why is it that some groups, some populations have such high numbers of unstably housed people? Like, what is going on? And that's where the structural drivers come into play. And so in the United States, we have a lot of amnesia and a lot of ignorance around the role of a long legacy of city policies, housing policies that have created the high level of unstable housing we have today. Urban renewal, you know, for many decades, policy of raising housing in poor neighborhoods, displacing everybody so that developers can come in and supposedly renew the area. And this led to a lot of trauma from displacement, a lot of shredding of supportive social networks among poor people who really rely on their neighbors and rely on friends for assistance, for childcare, for transportation, you know, you name it. When you're displaced from the people you trust and can rely on, your margin of survival is really disrupted. So, and then we have really insidious, more recent things like planned shrinkage I don't know how many people know, for example, let's take the South Bronx, which is the birthplace of a lot of harm reduction activism. But in the South Bronx, 40% of the housing stock burned down in the 70s and the 80s. Why? Because of a city policy called planned shrinkage, where city officials and developers got together and closed fire stations in poor neighborhoods, knowing that that would lead to burn down of the housing stock, but wanting to clear the area. And so, there's some really insidious policies that have led to the unstable housing that we see now. And now a lot of American cities don't make any accommodation for affordable housing. We're seeing widespread gentrification, displacement of people from low-income neighborhoods. So there are a lot of structural drivers of the patterns. So that is what I mean by structural drivers of social needs or social determinants. So I've been spending a lot of time kind of trying to preach that gospel, and my colleagues too. And so one of the terms that we've introduced to help clinical practitioners to think and act this way is structural competency, indicating, okay, we need to shift the focus from individual patient to what are the institutional, neighborhood level, policy level drivers of their health. And then what under competency, what can we do with the symbolic capital that we have as clinical practitioners? Because if we were to write an op-ed, if we were to testify for a policymaker, if we were to speak out about a policy, let's take decriminalizing drug paraphernalia. When a doctor, a nurse, a healthcare professional speaks out and says, this is a real urgent health need, that can shift the conversation because they have a special kind of symbolic capital. And of course, we need in clinical medicine to be collaborating with people who have skill sets we don't have. We're not policy analysts. We don't get that in clinical training. We're not community organizers. We don't have that skill set. So we need to be collaborating. So this is an approach that I've been, and these are the steps that I've been outlining. I feel as though this is probably old news to the people who are on this call, but this might be a convenient language or way of framing it for colleagues who don't understand why you're spending so much time on harm reduction activism, because that harm reduction activism is precisely the kind of structural intervention that we as clinical practitioners could be making. And I see we're out of time, but there are many different levels at which we as clinical practitioners can be introducing this. We can be working in clinics, in medical legal partnerships, working with peers, as part of the healthcare team. We can be working with non-health sector agencies like housing agencies. We can, and this is an example of harm reduction and addiction treatment in community. They're very creative things you can do when you partner with community-based organizations. My friend Ayana Jordan has been partnering with Black and Latinx churches to introduce harm reduction and drug treatment there in more trusted settings. And then public policy. That's exactly what you all are doing with the decriminalization of paraphernalia. So in a nutshell, that is, and then I just want to give you this. We invite you to join us. We have a website, structuralcompetency.org, with training materials and a way to sign on to our listserv and join the network.
Oh my goodness, that's amazing. I mean, as someone who attended Hopkins, I got my master's in public policy, and it was focusing on how to, around criminal justice and social policy, but I ended up taking many classes in public health and basically just ended up at the public health school all the time. And I was here for it. And then we got into the social determinants of health. And it's often said back to me as someone who is also a trained racial justice facilitator and workshop facilitator, again, with Baltimore Racial Justice Action. And I'm trying to marry all this work, policy and racial justice advancement. And then so often medical providers, my peers from Hopkins, so many people come back like, well, you're talking about social determinants of health. And I'm like, I am. And there is something missing. And I haven't really been able to say the words, but I always have a frown, and people know, okay, Rajani's going to have that frown when I say it. And I think Harriet and I both were just like, that's not the full picture.
Yeah.
And so I am just very excited because I feel like the structures, I just keep yelling history and structures. I think we're missing it. And that is so helpful. This framing is just, I'm so excited, and I'm very excited to explore that website and to talk about structural humility, because I think, yes, we talk about these topics, but we need to talk about these things in different ways. And that's
And
what
I'm excited for Baltimore Harm Reduction Coalition. You're actually doing this work. This is the work. And this is what more clinical practitioners have to be exposed to. If you really want to have an impact on overdose, that's what you do. You don't sit in your office and wait for people to come to you asking for a prescription. That's not how it happens.
yes. Oh my
They're
goodness.
lobbying for decriminalization.
Thank you so much for spending this time with us. You are just
Thank you.
a wonderful advocate. We are so happy to be in community with
Likewise,
you.
I'm
and-
happy to be in community with you.
Oh my goodness. Yes. I'd love to share. I know we're over time, but everyone, you're going to be fine. I'm going to share some last things. We're all going to be okay. I wanted to offer some closing thoughts and next steps, because we cannot possibly just leave it there. I'm sure we're all feeling, there's that hype energy. I am way too worked up. Like I just had a cup of coffee. So what do we do? All right. Rajani's thoughts. And this is based on, what I had expected us to talk about. And of course, I have so many other thoughts that are in that little bubble. But I will say, being vigilant about the separate systems created for white and BIPOC folks, for Black, Indigenous, people of color. When I say be vigilant, I mean figuring out how to identify those, right? I think there are obviously, we are learning here about the very clear different system around buprenorphine and methadone, and the messaging and the framing and the marketing. And I know in housing markets and so many other systems, we know that there are separate systems, and it feels often insidious, right? Like you have to really dig and find it. And then there's stuff that's just plain ass obvious. Like this is just obvious. And so we have to be vigilant and think through and use it as examples of historical racism and how that has a legacy and shows up today. It is so important to have these examples, to be able to go and say, we can't keep continuing this. We need reparations for that, right? Mm-hmm. And so that is one piece that I think is always important to continue to do, is to be vigilant about understanding these separate systems. BUP is great and should be accessible to everyone. I feel like that's not news, but I just wanted to put it out there that when we say, there is this system, and the part of the learning I had is I've been learning about BUP is, okay, this system that has been designed, or at least when we talk about the opioid settlement suits, really is really where I'm going with this. And we talk about this is so dangerous, big pharma is dangerous, medications are dangerous, and then buprenorphine and methadone get lumped into that conversation of medications being dangerous. And that conversation is so whitewashed. And so we have to break it down and say, okay, hold up, buprenorphine's great, and methadone can be great. And they all are really, really great when given within no barrier access to harm reduction, right? You need to get them. If IBR Reach is an example, it is a program that we work with, Reach Health Services. They offer myriad services for folks, including methadone maintenance, but also eye care and diabetes medication, like all sorts of healthcare. And they have a beautiful waiting room, and they have spaces where people can come inside and feel safe and dignified. And so that is an example of a type of place that offers so much, and it's about the way that they offer it, and the harm reduction philosophy that they claim as well, that they're part of. That's important. So we need more, or at least low, but preferably no barrier access to community-based harm reduction. And forever and always abolish the police. We don't need it. The social control needs to stop, and the police are the factor. The police are actors in the social control. So I'm always going to have that thought. So I wanted to offer those. I'm sure I'll have many more later. Okay, you probably have a lot on your mind, everybody. The great news is that these lovely, lovely folks, Cam Kerr and Harriet Smith, are going to be on Instagram tomorrow, 10:30 a.m. Eastern until 11 a.m. Tune in, get in the chat. You can learn the recap. You can digest with them. It's going to be a joy, because they are joyful people. Last couple of things I want to say is if you want to organize with us, please, medical folks, like we'll talk about this, medical practitioners and clinicians, please come to our Maryland Harm Reduction Action Network, organize with us. Our next meeting is in 2 weeks, and you can register at tinyurl.com/MRAN2021. I'll ask my colleagues to throw that in the chat. So I can't remember what day that is. December 2nd, I think, 4 p.m. Eastern. We have t-shirts that say decriminalize paraphernalia. They're pretty cool. If you buy one, all of the proceeds go to support our policy advocacy work to actually decriminalize paraphernalia and do more. So please buy a shirt, buy a shirt, buy a shirt. I'm wearing the shirt. It's very comfortable. See, shirt. So buy it. You can go online. We're going to put that in the chat too. Surprise, save the date. We are doing our 5th annual Harm Reduction Advocacy Days event, February 2nd and 3rd via Zoom. We just wanted you to know about it. We wanted to announce it. You don't have to do anything, but know that it's happening. It's going to be in February during Maryland legislative session. Last but not least, let us know what you think. Thank you, thank you. We always want feedback on our events. It helps us to improve and continue to grow and create events that you want to see and be part of. Woo! I did that as fast as I could. That's everything. Thank you so much again, Dr. Hansen. Everyone, if you want to, we're going to stop the recording now. Thank you. Yes, thank you so much. It's such a joy to